In the last video, we spoke about the bloodstream infections. Here we'll talk about cardiovascular infections, mainly infective endocarditis. So, which all parts of the heart can get affected? So, obviously the endocardium, which is the innermost layer, and that infection will be called as infective endocarditis. Myocardium, or the middle layer, the muscular part, so that is called as a myocarditis. The pericardium, the outermost layer with all the connective tissue, fat, everything. It also has a very minimal amount of fluid to make sure the lubrication, so that can be a pericarditis or pericardial effusion. Apart from that, heart is supplied and in and out comes the major vessels, so you can have a myocardic aneurysm or infective endarteritis. Same way, when there are some devices involved, that's called as a catheter-related bloodstream infections and suppurative thrombophlebitis. Finally, you have the autoimmune, which is the acute rheumatic fever. Now, we'll talk about the infective endocarditis as such. So, that is basically when the infection happens in the heart valves, which can be seen as a bulky vegetations. So, it will contain a little bit of platelets, fibrin. Along with that, there will be some inflammatory cells and the bacterial colonies. So, these are seen on the areas where the heart's pressure, the pumping pressure is low. That is on the, if at all the patient is having a ventral septal defect, it can be seen. So, it can be either a acute endocarditis or a subacute endocarditis. This is how it looks on a histopathological image. These are the vegetations which have already been seen in all of textbooks. So, if you want to differentiate between acute and subacute, acute endocarditis is a rapid infection compared to subacute endocarditis, which is comparatively slower. Acute happens in a normal cardiac valve and subacute happens in somewhat slightly damaged valves. So, obviously, the acute endocarditis requires a highly virulent organism like Staphylococcus aureus, whereas subacute, even a lesser virulent organisms like wooden streptococci can cause infection. Acute endocarditis, as the name suggests, the mortality and morbidity are very high even with treatment. The subacute is comparatively lower, and the incidence of patients developing acute endocarditis is lesser with a acute site, whereas on a patient who is already having a damaged valve, so subacute endocarditis rates can be slightly higher. So, what causes this infective endocarditis can be a pre-existing cardiac defect, maybe a congenital valvular disease, or use of intravenous catheter or prosthetic valve replacement. So, wherever the normal endothelium is slightly damaged or there is any kind of an instrumentation, there is always a risk of developing infection. So, when there is an endothelial injury, it is very rare in the normal valves. So, when the valves become defective, what happens? A normal smooth blood flow in and out of the heart will be slightly changed to a turbulent blood flow, which damages the endothelium. Or when you are going to use intravenous cardiac catheters, that can also damage the endothelium, where the damage will be tried to be healed with deposition of platelets and fibrin. That is what we call as a non-bacterial thrombotic endocarditis. Here what happens? Slowly, when the thrombus is there, bacteria will come and attach. It can be either a transient bacteremia or it can attach there inside the fibrin mesh, and slowly they can start multiplying. So, once they start multiplying, what will happen? Will be more covering of the area with layer of fibrin and platelets to prevent the bacteria from proceeding further. So, this is what we see as a vegetation. So, it's a combination of platelets, fibrin, inflammatory cells and microorganisms. So, obviously, because of the pumping action, this bacteria and vegetations can slowly get dislodged and they can mix with blood and go to different various sites where they can cause some symptoms. Organisms, if you see, this is most important, the Staphylococcus aureus, followed by coagulase negative staphylococci, the pneumococcus group or the streptococcus group, and the most important is Hasek organisms, which basically comprises of your Haemophilus species, Aggregatibacter, Cardiobacterium, Echinella and Kingella. After this comes your Enterobacteriaceae, Pseudomonas, Candida and Diphtherids. If a native valve That is, the patient is not undergone any kind of a surgery. The most common one to cause infection is Staphylococcus aureus, and with a streptococci, if it's a community acquired endocarditis. If the patient has undergone surgery for prosthetic valves, if it is just less than 1 year from the surgery period, it can be intraoperative or nosocomial infection, which is with Staphylococcus aureus or Coagulus negative staphylococci. Late or more than 12 months, it is mostly because of the Widow's streptococci. Whenever there is a methicillin resistance in staphylococci, whether it's Coagulus positive or Coagulus negative, the incidence is more with Coagulus negative staphylococci. IV drug abusers, you see mainly Enterococcus and Staphylococcus, which affects the mitral valve. Lesser common is the Pseudomonas candida and Lactobacillus, Corynebacterium, all those things. On the right side, where the flow is much more severe or pressure is more, can have MRSA and Staphylococcus aureus causing the infection. So the base idea is that Staphylococcus aureus is the one which causes infection in all categories of patients. There is something called as a culture negative endocarditis, where we try to take the blood sample and try to isolate the organism which is responsible, but we are not able to do that. Why? It might be because it is the patient is already on antibiotics, or the infected organism is a fastidious one. It can also be nutritionally variant streptococci or Hasek organisms, Coxiella, Bartonella, Brucella. All those things don't grow on routine cultures. So for diagnosis, one thing is you need a high index of suspicion as well. So what is the source for this bacteria? It can be from the oral cavity. A simple act of brushing or coughing can release some organisms which can go and settle off in a conducive environment. Staphylococci from the skin. Hasek organisms which can form a normal commensals in the upper respiratory tract, or Enterococcus from the gastrointestinal tract. What are the clinical features? Clinical features you can mainly divide into non-cardiac and cardiac clinical features. So non-cardiac, the patient can have fever, chills and sweats, little bit of weight loss, tiredness, myalgia, arthralgia, some emboli here and there. There can be enlargement of the spleen, clubbing, petechiae. Because of this thrombus, can be neurological manifestations or peripheral manifestations can be there. Cardiac wise, you can see a new murmur or worsening of a pre-existent regurgitant murmur, and that is much more useful in diagnosing when there is a normal cardiac valve. So what are the basic things you are going to see in your routine screening? You can have, look for anemia, leukocytosis, microscopic hematuria, elevated biomarkers like CRP, elevated rheumatoid factors and ASR. Specifically, what do you want? You want to do, or you want to isolate the culture, the organism in culture. So basically, you take a set of blood cultures. So one, you can take 2 blood culture sets at the interval of more than 12 hours, or the most preferred one is you take 3 sets of blood culture within the span of 1 hour with 30 minutes gap in between. That is, the first set, as soon as you suspect, you take a first set, after 30 minutes, second set, and another 30 minutes later, you take a third set and send it for culture. Always be sure to mention your suspicion so that the lab has an idea of what it has to look for. For this, you have what is called as a modified Duke's criteria to diagnose for specific clinical diagnosis. So first of all, you need a positive blood culture with typically known infective endocarditis organisms separated from 2 separate blood cultures, or you can have a persistent positive blood culture with a single organism, which can be a atypical organism for your infective endocarditis, or you can see look for single positive blood culture for Coxiella or phase 1 IgG antibody titer of more than 1:800. Along with that, you can also look for endocardial environment with the positive echocardiogram. It can be an oscillating intracardiac mass of the valve, or an abscess, or a partial dehiscence of the prosthetic valve, and also a new valvular regurgitation. So these are the major criteria. Then you have the minor criteria. Again, we'll, just like last time we had in our bloodstream infections, we'll go by our own mnemonic. Here the mnemonic I have coined is Indian Medical Association feels vibrant. So I is for immunological phenomena, M for microbiological evidence, A for at-risk heart, F for fever, and V for vascular phenomena. Let's see one by one. So first you have the immunological phenomena that can be glomerulonephritis, Osler's nodes, Roth spots, or rheumatoid factor. Now we'll talk about the Osler's nodes and Roth spots in the next slide. Then you have the microbiological evidence, which is positive blood culture but does not meet the major criteria. Third, predisposition, that is a patient who is already having a predisposing heart conditions or is a known IV drug abuser. Fourth is fever of more than 100 degrees Fahrenheit. And finally, you have the vascular phenomena, which can be a major arterial emboli, septic pulmonary infarcts, myocardic aneurysms, intracranial hemorrhage, congenital hemorrhage, or Janeway lesions. So, this Osler's nodes and Janeway lesions were identified in late 1800s. The Osler's nodes, and these are basically a microemboli which can settle off in different areas, causing some particular lesions which are known to be associated with infective endocarditis. So first one is Janeway lesions, which are non-tender, small, erythematous or hemorrhagic macular, papillary or nodular lesions on the palms and soles. It can range from few millimeters in diameter. Then you have the Osler's nodes, which are tender, purple-pink nodules around 1 to 1.5 millimeters on the distal fingertips or hypothenar and thenar muscles. Roth spots, you have the retinal hemorrhages. This is seen in variety of conditions, where 80% of them seen in bacterial endocarditis. This can also be associated with many other conditions, but when you see this on the background of a suspected infective endocarditis, you think more about these Roth spots. This is one good picture which I got from internet just for the purpose of explaining, not for anything else. So let's see. So first we have the clinical symptoms. So the patient can have poor dentition, indwelling lines, IV drug abuse, artificial valves. These are all the predisposing factors for infective endocarditis. What are the signs and symptoms? So what you have, the symptoms: fever, chills and rigor. They can be arthralgia, they can be myalgia. So what do you see as signs? You can see heart murmurs, Roth spots, vegetations, splinter hemorrhages, Janeway lesions, Osler's nodes, and petechiae, which can be there in infective endocarditis. So what is the basic idea? Now using the modified Duke's criteria, you can get two major criteria. Then obviously you have a definitive diagnosis of infective endocarditis, or one major and three minor criteria, or five minor criteria if they are present. Then you can term your patient as having infective endocarditis. The add-on investigations, you can do serology for Brucella, Bartonella, Legionella, Chlamydia, and Coxiella. And if possible, if the vegetations are isolated and taken out and sent for sample, then you can look for the pathogens there. You can also do some special stains like PAS for Treponema. Then you have the direct fluorescent antibody techniques, polymerase chain reaction, and echocardiography. Treatment wise, you have the Staphylococcus aureus. If it's a native valve and if it's a methicillin sensitive Staph aureus, go with cloxacillin or nafcillin for 6 weeks. If it's MRSA, straight away go for vancomycin for 6 weeks. If at all is a prosthetic valve, then you can add on rifampicin for 6 weeks and gentamicin for 2 weeks. The suspecting middle streptococci, the native valve, you can go for penicillin or ceftriaxone for 4 weeks, and if it's a prosthetic valve, you can add gentamicin for another 6 weeks. It's a HESEC group of organisms, ceftriaxone or ciprofloxacin for 4 weeks and 6 weeks if it is case of a prosthetic valve endocarditis. So, as a medical student, what all you need to mainly concentrate is basically what is infective endocarditis, what is Duke's criteria, what are those lesions which are there, and obviously the treatment pattern. I've taken some images from internet just for the purpose of explaining. So I hope you like this video. Kindly do like and share this video to the maximum possible, and subscribe to my channel for more interesting content. Thank you.